Hi, I'm Neel Desai. I'm a cornea, cataract, and refractive surgeon at the Eye Institute of West Florida in Tampa, Florida. And my practice is really divided into several segments. Certainly I focus on cataract and refractive, corneal refractive, cornea, true cornea, corneal transplants and such. But a larger and growing segment of my practice has by necessity become the treatment of ocular surface diseases through a variety of means. And really it's because our outcomes in the other segments of our practice, particularly cataract and refractive cataract and cornea refractive surgery, is predicated on the attention that we give to ocular surface diseases in the perioperative period. What we've all experienced in our clinical practices on a daily basis is patients that come in with florid ocular surface disease. And somehow, surprisingly, they're completely physically asymptomatic. They may have years ago had the physical symptoms of dry eye, but at this point they come in and they say, "Doctor, my eyes feel fine. I don't think I have dry eye, though everyone tells me I do. In fact, I have excessive tearing pouring down my cheeks at almost all times. My real problem is that my vision is poor, or my vision fluctuates from moment to moment." And that's a tip-off to me, and that's really sort of the epiphany that I had long ago, that there's a mechanical component to dry eye. We've all had the sort of paradoxical patient that seems to have dry eye and typical ocular surface disease, but they simply don't respond to all of the typical conventional therapies that we might throw at them, from artificial tears and tear optimization to hot compresses and lid margin disease treatments, addressing the Demodex and the meibomian gland dysfunction. They may not respond to IPL or LipiFlow or tear care therapy. And they may not respond if we understand inflammation being the root cause of all ocular surface diseases. They may not even respond to immunomodulatory therapy like lifitegrast or Restasis or Cequa now. And so these paradoxical patients that don't seem to respond to targeted treatments that try to address some of the underlying causes of ocular surface diseases, there's a missing X factor. And that X factor is this mechanical dry eye concept, or conjunctivochalasis. Now, I steer away from using the term conjunctivochalasis, certainly with patients, but even in discussing it with my colleagues, conjunctivochalasis is perhaps the worst misnomer in all of medicine. And that's because it has nothing to do with primarily the conjunctiva, nor is it chalasis or excess conjunctiva. In fact, to really truly understand the underlying pathophysiology, we have to understand that it's actually a primary disease of the Tenon's fascia, and therefore it's sort of like a basement membrane disease of the conjunctiva, if you want to think of it that way. With chronic overexpression of inflammatory mediators, the Tenon's fascia will begin to dissolute or become dissolved and unhealthy, and that leads to a loosening, not an excess, but a loosening of the overlying conjunctiva, a foreshortening of the inferior fornix or the tear reservoir, and it will also allow for the prolapse of orbital fat into the inferior fornix, further foreshortening that tear reservoir. And so no wonder artificial tears don't seem to help. They have nowhere to stay. Immunomodulatory therapies don't help because while they might treat the inflammation, it's certainly not changing the anatomy or the pathophysiology of the anatomy and reversing that process. And certainly those drops don't have perhaps enough contact time or bioavailability because there's no tear reservoir for those drugs to remain on the ocular surface long enough to work. And so we have to offer now our patients a solution for the mechanical side of ocular surface disease, or the mechanical side of dry eye syndrome. And there's a large segment of our patient population that falls into that category. Patients who seem to not have any physical symptoms of dry eye, largely because at the end of that ocular surface disease spectrum, where conjunctivochalasis lies in wait, so does neurotrophic keratitis. And so these patients, oftentimes with chronic inflammatory mediators present, they'll have denervated corneas and a relatively neurotrophic cornea. And so they may no longer feel the physical symptoms. Hence, it's our responsibility to help patients connect the dots between perhaps what they have as visual symptoms of conjunctivochalasis or mechanical dry eye to the actual pathophysiology and understand why this treatment approach, a minor procedure that takes about 12 minutes in an operating room, it's very comfortable, will seem to work when other treatments have failed. The treatment is essentially, as I describe it to patients, a mini facelift for the eye. We're removing wrinkles that have formed on the eye over time due to chronic inflammation and dryness. And I explain to patients that on your own skin, if you never put good moisturizer and had an inflamed skin surface, the skin's going to turn rough and brittle and wrinkled very quickly and become uncomfortable. And the same is true on the skin surface of your eye. So when I explain it in that sort of non-threatening way, patients kind of understand intuitively that there's a mechanical or an anatomical problem that won't be reversed by conventional topical therapies anymore. And so I think they're very receptive to the idea that we're going to do a mini reconstructive or restorative procedure to their eye to smooth things out and restore the normal anatomy to that tear reservoir so that their other conventional long-term therapies will actually work better. Over the last few years, in my experience, having performed hundreds of reservoir restoration procedures for patients with mechanical dry eye or conjunctivochalasis, I've noticed a few things. One, I've been pleasantly surprised at how immediate the effect is. In fact, patients often ask me post-op day one, when can I do the other eye? And that tells me everything I need to know about the efficacy of this procedure in terms of providing comfort for the patient and allowing them to resume their normal life, their normal visual activities, their normal visual lifestyle, as well as allow the other conventional treatments to work a little bit better. If they're asking me this post-op day one, it tells me that it works. So I discovered that this is a very prevalent issue in our practice, and so many patients have been treated historically very dismissively for their dry eyes because they've been recalcitrant toward typical conventional therapies. But once I found myself having a solution in my toolbox that was easy, efficient, and efficacious and safe to perform, I found that I was really able to deliver satisfaction to my most miserable patients and turn them into the greatest fans. And so I urge all of my colleagues to start to look for those patients within their own practices. They exist for all of us, and start treating it because we now have a powerful tool in our toolbox to treat these patients effectively.